Would you like to know how your patient's airway, breathing, and sleep may be related to their dental problems, and how asking why may be a critical factor enabling you to render the most appropriate and effective care? Dr. Witt Wilkerson, the Director of Dental Medicine at the Dawson Academy in St. Petersburg, is my guest today. He's about to reveal exactly how all these things are related, and we're starting right now.
And now, Amazon #1 best-selling author, Dr. Tom, the Gems Guy, Orent.
Today I'm speaking with Dr. Witt Wilkerson. Witt joined Dr. Pete Dawson's private practice in 1982, where he's a partner. Dr. Wilkerson lectures worldwide on restorative dentistry, dental occlusion, TMD, airway and dental sleep medicine, and integrative dental medicine. He's an adjunct professor of graduate studies at the University of Florida's College of Dentistry and a former associate faculty at the Pankey Institute. Witt, thank you so much for taking the time to be with us. How are you today?
I'm doing great, Tom. It's great to hear your voice.
Hey, it's good to hear you again. And as I said, when we finished that first talk that we did when you presented, I am so overwhelmed, so happy to have found what you're doing, your research and what you're doing in dental practice to integrate medicine. And so if any of the viewers didn't see that first video, I would highly recommend, I'll put a link to it in the description below. I would urge you to see the first video, but let's go on, and Witt, go ahead and take it away.
Thanks, Tom. Thank you so much. Well, I wanted to talk in this session together about airway and breathing. Airway and breathing is getting a lot of press in dentistry. I know there are airway sleep apnea courses in every community going on probably this weekend. Very, very popular subject. But what I want to show you is that there's a lot more to airway and breathing than sleep apnea. Sleep apnea is kind of the tip of the iceberg, worst case scenario, much like diabetes would be for blood sugar level and insulin resistance. I want to talk to you about the bigger picture of this and how it begins. So we're asking a lot of questions about why things happen as we move forward in dentistry. So when we think of airway, breathing, and sleep, we think of sleep apnea. Knowing that sleep apnea disrupts your sleep cycle, and therefore you can get sympathetic dysregulation, meaning that you're turning on the stress hormones, you're exciting the sympathetic nervous system response, that fight or flight response, so that when you're getting into deeper stages of sleep, if your oxygen levels begin to drop, there's an alarm going off saying, hey, we're choking to death here. And then you get aroused out of deeper to light sleep, if not completely awake. With that goes the release of stress hormones and excitement of heart rate and cardiovascular excitement as well. So not good. Insulin resistance is part of that elevated sympathetic dysregulation. Hypertension and cardiac arrhythmia go along with that, chronic fatigue, and ADHD type symptoms. I'm talking about not only ADHD that may occur in children, as we'll talk about, particularly those that struggle from allergies and poor sleep, but throughout a lifetime, we can have memory effects from airway, breathing, and sleep disorders, memory deficits, heart attacks and strokes, dry mouth, perio, and caries would be an oral side effect. So if you see a young person come in and they've got inflammation around their anterior teeth and maybe caries in the anterior region of their mouth, be aware that it's very likely that they're a mouth breather. And we're going to show you that mouth breathing is really dysfunctional breathing. But also, as we look at this whole integrative dental medicine model, we realize, too, that airway and breathing and sleep disorders can create inflammation that's systemic and also can create TMD and malocclusion type issues that we're used to seeing every day, but we never associated with airway and breathing issues. So we're going to talk about that more right now. Tremendous work was done in the late 70s, early 80s at the University of Michigan. Dr. Harvold and McNamara and others there did work, and Harvold's work is very interesting. Working with rhesus monkeys, he actually took these baby monkeys and put silicone plugs in their noses, forcing them to breathe through their mouth. some of the young infant monkeys actually died because they couldn't convert to mouth breathing. Those that did convert, they found that all of the experimental animals whose noses were blocked gradually acquired a long, narrow facial appearance, long premaxillas, and dental occlusions. They had malocclusions, crowded dentition, sometimes anterior open bites compared to the controls. Now, this is in the first generation. So this was an environmental change, or what we call epigenetics, environmentally induced change in expression genetically and cell development. McNamara, who headed up that program for the Center for Human Growth and Development at University of Michigan, summarized the work that went on for years and years there at the University of Michigan. And his summary was this: there's a relationship, a direct relationship between upper airway obstructions, that means I can't breathe through my nose, and undesirable dental and craniofacial development. Significant improvements are seen when the obstructions are removed. These obstructions could start with allergies at a young age, different problems within the nasal airway that could develop and therefore affect the ability to breathe normally through the nose, which is really the way that we're designed. So this is a perfect example of function and form, and how, in this case, form, deviant facial development, follows the function or the dysfunction of obstruction in the nasal area. So as you see the example here in the black and white photo of one of those monkeys who had gone through that experiment with blocking their nasal airway, we're reminded, aren't we, when we look at that appearance, of an appearance like this in an adult human, where we see crowded arches, anterior open bites, gummy smiles, V-shaped arches, and cross bites. The list goes on, doesn't it, of some of the things that we observe. Kevin Boyd, an amazing pedodontist, a world-renowned researcher in this area of airway and breathing disorders in children from pre-birth at Lurie's Children's Hospital in Chicago. He sent me these photographs of 3 different examples. That's one child on the left, and then one on the top right and bottom right. And they all have something in common, even though their appearance is very, very different. What could there be in common with a child with severe crowding, an anterior open bite and tongue thrust, and bruxism and severe wear of the teeth? In this case, the answer is disordered mouth breathing and breathing disordered sleep. Fascinating stuff. And it all relates back to what we learned from Dr. Dawson about the neutral zone. The neutral zone, remember, is that neutral corridor where teeth erupt and are positioned according to the opposite forces of the tongue pressure outwardly and the lip and cheek pressure inwardly. So when you think of the neutral zone in these children, you can see how it has been affected, that is, by tongue positioning and breathing differently through their mouths. You can see how it's had an effect. Look at this upper arch and think about what's going on here with the neutral zone, where when the tongue fills the vault of the maxilla, you get a well-developed, rounded-out arch of straight teeth. And in many cases, that includes eruption of the third molars because there's room for them. So when you look at this maxillary arch, you have to say the tongue hasn't spent any time in the roof of the mouth. It's been low in the floor of the mouth, indicating that this patient, who we haven't even met yet, perhaps, is definitely a mouth breather, most definitely would have upper airway restrictions, probably would have some airway problems affecting their sleep. And so when we look at this, we understand that just as form follows function, deformation follows dysfunction, in this case, dysfunctional breathing, mouth breathing. And so what do you see here? Well, we see a severe dental malocclusion, maxillary arch, and some palatal inflammation. But as we start to ask the question, why do we see this type of deformation, we may very likely find some background history where we find that the child had allergies, As a child, this person had allergies, developing what we call upper airway resistance syndrome, which is kind of the precursor, as it were, to sleep apnea. That is, I have trouble breathing through my nose. My nose is congested or blocked, and therefore we convert to mouth breathing as a result of that, perhaps driven by the allergies, most likely. Now with mouth breathing, you can develop perhaps tongue thrusting and craniofacial dental deformation, just as we see in this photograph. But also, as you learn more about this, you realize that can possibly also go along with inflamed and infected adenoids and tonsils, chronic breathing, disordered sleep, chronic release of stress hormones because of disordered sleep, chronic hormonal imbalances, chronic fatigue and poor memory, ADHD, TMD, obstructive sleep apnea, type 2 diabetes, high blood pressure, and cardiac arrhythmia can all come from that source, which is very interesting, isn't it, and amazing. So how would the quality of life be if this was the worst case scenario? In fact, we could ask, how would this affect life expectancy, what we're seeing in the mouth, if it were related to all these different possible effects that could be going on simultaneously? You realize now that we in dentistry can begin to identify things that are very, very significant. Last January in 2019, we had our third annual Dawson Academy Airway Symposium here in St. Petersburg. And we had some of the top people in the world that are doing research and speaking and lecturing on airway disorders. And we went to dinner together with Dr. Dawson. And Pete sat down and reflected on what he had heard from these different outstanding speakers who are researching airway breathing disorders from childhood through out a lifetime. And he commented on what he heard. And I want you to listen to his wisdom here as we recorded on actually just a phone, we recorded his words.
The dentist becomes a critical observer when they see anything that would be an interference to the harmony of the respiratory system. High vault, narrow arch. For years have preached that this is the effect of an airway problem. So that's probably 30 years ago. We've been preaching this, and we say you have to expand the arch to make room for the tongue in the ball. But if you do that, you get a perfect solution. It's going to fail if you don't take care of the airway problem. So we have to take what y'all are teaching and what we teach and combine it.
So just amazing words from Pete, who most of you are aware now passed away this July. So it's very emotional and sentimental for me just to listen to Pete and to hear his words of wisdom. But basically what he's saying is that we've looked at malocclusions for years and years and years and described these anterior open bite crowded arch situations and how we can expand the arches and we can correct the occlusion. But if we don't address the cause of the malocclusion, meaning why this patient has a tongue thrust, which can very likely be related to airway and breathing disorders, then if we don't address that too, we're going to find relapse in our dental corrections. So asking why and tracing back why these problems are occurring is a very important part of what we do. So not only do we orthodontically correct malocclusions, not only do we orthognathodically in some cases correct severe malocclusions, but we also include oral myofunctional therapy where we have therapists working and retraining the patient to breathe through the nose, to swallow properly, to put the tongue in the roof of the mouth. We have to work with the ENT in some cases to open up the nasal airway if there are obstructions there that make it impossible to breathe through the nose. And this becomes part of our total treatment plan of doing comprehensive dentistry and integrative dental medicine. It's so exciting. I've been seeing for years, Tom, since 1982 when I joined the practice with Pete. I've been seeing TMJ patients on a regular basis from all over from dentists referring to us from all over the world. And so here's where we have been for so many years, including myself until recent years. We have a patient come in and they say, yes, I've got popping and clicking. My muscles are sore. I think I may clench or grind my teeth. My bite doesn't feel good and there's wear on my teeth. My teeth are not even and level. My muscles are sore to palpation. Joints are sore to palpation. Load testing of the joints is tender. There's a hit and slide in the occlusion. We listen to the joints with Doppler auscultation. We hear scratchy crepitus in the joints, and we get an MRI of the joints, and we may see some changes in osteoarthritis or disc displacement, things like that. So we immediately come up with our diagnosis, which is a TMD disorder. And so historically, we will ask ourselves, well, is this a surgical candidate or is this someone who we could try to work with a splint? What type of splint are we going to make? But that really doesn't explain why they're having all of these issues. It's just, revealing to us their current condition. So typical in dentistry and what we've learned in school or beyond was what type of splint should we use for this TMD patient? But what if we went in and we evaluated the patient and we saw a scalloped tongue, which represents a lack of room in the mouth because of a crowded dental arch, and we saw enlarged tonsils and no room in the posterior part of the mouth, or we saw that there was a tongue restriction, a tongue tie, and a Mallampati high score where the top palate is down the back of the throat. And we begin to evaluate that part, and we come up with just as many positive check marks for airway and breathing and sleep disorders as we did for TMD and occlusion. Well, that can completely change our diagnosis and can completely change our treatment plan from what we were thinking about before. So let me show you this as an example of your next TMD patient, quote unquote. So let's say this young teenage lady comes in to see you and she says, my muscles are sore, my joints are sore, I wake up frequently in the morning with headaches, I'm tired all the time, and her bite isn't good. And we would all look at each other and say, well, that's a classic TMD patient. What type of splint should we make? But let's go home with her tonight and watch her sleep, and I want you to see how she sleeps. Does she breathe through her nose or through her mouth? Is she getting into deeper stages of sleep, or is she struggling to breathe and really very restless, staying at a very light level of sleep, which is not restorative? If she woke up in the morning and said, I feel terrible and my muscles are sore, and in fact, I've got a headache this morning, would that surprise you? So you see, the diagnosis and asking why is something where we have to really dig in. How's the quality of life? What's the life expectancy? What type of TMD splint should we use? The fact is that if she has an airway and breathing disorder and we put in a traditional CR splint, we may actually be giving her less room to breathe, which could elevate her sleep disordered breathing to a higher level than it was before we saw her. And so that might be exactly the opposite of the right next step of treatment. So one of the things we've been using a lot that anyone on this webinar could use easily would be high resolution pulse oximetry. This is simple, inexpensive, good screening information where we're trying to see what's going on with the oxygen levels during sleep. Are the oxygen levels bouncing around a lot? Is the patient dropping below 90% oxygen saturation at any point in time? Or even between 96% and down to 92% bouncing around would be considered unacceptable. Is the heart rate going up and down? Is sleep fragmented? We can do simple pulse oximetry. This is a sleep sat from that you can purchase through Great Lakes Orthodontics. Is a great supplier of this, and we work closely with them. But you can look at this readout on the right-hand side and get an idea. Are they in the green zone, the healthy zone, or are they getting into the red or orange zone, which means that this is not a healthy situation, and perhaps we need help. We need to see a sleep physician. We need to get more expertise to work with us. Here's a new patient that I saw, and I hope as we're having this discussion that you're going to see at least 4 things here that are red flags for you for breathing, airway, and possibly sleep disorders. First of all, look at her tongue. When she raises her tongue as high as she can, it's severely tongue-tied. You also see the outline of the tongue is scalloped, which means there's not enough room, highly correlated with breathing disorder and sleep disorder. Where's the uvula? The uvula is halfway down the throat. This patient is a Mallampati 4, which is also often highly correlated with a lack of airway space in the back of the throat. And then look at the maxillary arch. Do you see the omega shape to the posterior teeth? So the tongue has not been filling the vault. That is the constricted arch that is related to mouth breathing and a lack of proper seal and closure of the mouth on breathing through the nose. And finally, she has a little bit of incisal edge wear for a 21-year-old on the incisors of number 7 and 8, indicative of someone who's actually been hanging out forward, rubbing on the front teeth in that edge-to-edge position. Why would you do that? That's not an occlusal issue. That's a comfort issue. That's a breathing issue. Let me tell you her history. She was referred to me as a 21-year-old, quote, TMD, unquote, patient. She went to the emergency room a week before I saw her in the middle of the night because she woke up thinking that she was dying. All tests at the hospital were negative, and she was told by the emergency room physician that she was having an anxiety attack. Well, that's exactly right. She was having an anxiety attack because she couldn't breathe. And so here she's sent home with something for anxiety. And in fact, I hope she didn't take the anxiety medication they may have prescribed before going to bed at night, because that could have actually decreased her respiratory activity and put her at higher risk if she's a patient with sleep apnea. So you see how much we can identify by looking in the mouth. Severe tongue-tie, scalloped tongue, Mallampati 4, maxillary retrusion, omega-shaped maxillary arch and incisal edge wear, all red flags for airway problems and sleep disorders. What about this patient if he came in to see you? I hope as you begin to think about this and you see an enlarged neck, which anybody with a neck circumference of 16 inches for a female, 17 inches for a male, is at very high risk for having breathing disorders and breathing disordered sleep. He looks a little bit like he might have sleep apnea, doesn't he? Hair's messed up, enlarged neck. It's like he just rolled out of bed. But he comes in to see me because of his teeth and the wear that he has on his incisors. And I want you to know, when I have him match up the incisal wear on the porcelain of the upper and lower incisors, which he's chipped and worked grooves into, we can see that this is his favorite place to hang out. That's not an occlusal issue. That's not a problem of restricted envelope of function or something along that line. This is because this patient can breathe when he comes out into that forward posture, and that's where he is trying to live. So with that, we see he's got a Mallampati 4. We can't see his uvula at all. I think that there could be an airway problem, don't you? So what do? When we see someone with this background, we may want to consider going ahead and doing a sleep study. You could do a high-resolution pulse oximeter and get a clue. I know that it's going to be very erratic. So we could either in our office or through a referral to a sleep physician or to a third party that can send this to a patient's home, actually do a home sleep test, which is a home version of a polysomnogram. And so in this case, we did that test in our office, and we found that his AHI was 68. Severe is 30 or greater. So his AHI is very, extremely dangerously high. But if we look at his medical history, look at this. He also came in with high blood pressure. He came in with cardiac arrhythmia. He came in as a heavy snorer. He came in with daily fatigue and sleepiness. So all of this starts to fit together, and it's something that we as physicians of the masticatory system can easily identify and should. Mark Cannon is a wonderful colleague who is a pedodontist, also working out of Lurie's Children's Hospital in Chicago. And Mark is probably, in my opinion, the top oral microbiologist in the world. We serve together on the board of the American Academy for Oral Systemic Health, and we stay in touch with each other. I want to share with you a very sad email that I received from Mark on New Year's Day this year, 2020. He says, "My little brother Jim had a cardiac arrest on Christmas Day. I flew to Laredo the next day and stayed with him in the ICU. He was totally unresponsive. His pulmonologist arrived and told me, and he was very emotional about it, that my baby brother had died from sleep apnea. That the sleep test he was supposed to have done was denied by the insurance carrier, as then, of course, was the CPAP. The pulmonologist told me that it was a tragic and unnecessary thing. The CT scan showed that there was massive brain necrotic areas due to oxygen deprivation. Life support was removed, and my brother slowly passed away on comfort care. His journey ended last night. Jim was 59 years old." This is terrible, terrible news. And what caught my eye here was that the sleep test he was supposed to have, which means a polysomnogram in a sleep center or hospital, was denied by the insurance carrier, and therefore he didn't receive treatment. I, in my own practice, do a home sleep test for $150. We can do a high-resolution pulse oximetry for a few dollars. And these are things that we're doing daily on every patient who is even suspicious for having a problem. We don't need insurance to do that. If the patient resisted in doing a home sleep test, I'll give it to them. But this is the kind of information that we can obtain and really begin to change and save lives like Jim, which should never happen if under the care of excellent physicians and dentists. I found that there are three nice breakouts demographically of patients with breathing disorders and breathing disordered sleep that are easy to identify, and that is young children who come in with common signs and symptoms of ADHD. We don't know what percentage of children diagnosed with ADHD actually struggle and suffer from allergies and poor sleep quality. So every child that's diagnosed or thought to have ADHD, it should be asked, does the child have allergies? Does the child struggle with sleep? And then to test those two things out. Those can be life-changing. I want to highly recommend to you, as you listen to this, to consider going on YouTube and looking at a video that's entitled Finding Connor Deegan. This is a video filmed in Chicago, and this was a patient of Kevin Boyd's, filmed by the American Academy of Physiologic Medicine and Dentistry. That's about a young man who had ADHD and his life was turned around in a matter of months. Please watch Finding Connor Deegan, and you'll really, really get a good understanding of what we're talking about. Young adults with TMD.
Hey, Witt, can I just jump in just for a moment?
Yes, sure.
I just wanted to say that for the viewers, I'll put a link to that video right below in the description, and that way it's an important video. We think you should watch it, so look in the description below.
Thank you, Tom. That's great. Dr. Christian Gimeno, who headed up the Stanford University Sleep Center, really the godfather of sleep apnea. In fact, he coined the term sleep apnea. He recently passed away 1 month before Pete. He was also about 80 years old. But Dr. Gimeno did an exhaustive amount of study at Stanford on young, thin adults that were struggling with fatigue and poor sleep. And what he found was there was a whole community there that is all around us of young adults who don't have full-blown sleep apnea, meaning they don't stop breathing for extended periods of time all through the night, but they struggle breathing and turn on the same sympathetic nervous system response as those with sleep apnea. And there are millions and millions and millions of young people around the country with that. But it's very interesting to know that the common symptoms of that are chronic fatigue, wake up unrested, wake up frequently with headaches in the morning, sore muscles, sometimes clenching and grinding, which may be part of trying to open up the airway. And it really basically is a classic list of symptoms that we would call TMD. And so with that in mind today, when I see a young adult come in with TMD signs and symptoms, I'm thinking very strongly about the fact that they very likely will have some breathing and airway and sleep disorder. And we're finding that that's exactly the case. And then with middle-aged and older adults, just as we talked about ADHD affecting cognitive and issues, so with middle-aged adults and beyond, as we see more weight gain that can be related to hormonal imbalance and more true obesity that can perhaps occur, then we see more obstructive sleep apnea. But there are also middle and older aged adults that aren't overweight, that can be normal weight and even thin and have sleep apnea. But with that, you'll see very often cognitive impairment, memory issues, and we see patients coming in saying, I think I'm starting to develop early signs of Alzheimer's. It often can be actually not Alzheimer's, but dementia related to oxygen deprivation, just like we saw with Mark Cannon's brother. And so that is completely reversible. And there's been a number of studies at UCLA and other schools showing that patients that were diagnosed with obstructive sleep apnea put on a CPAP for a year or less, and they saw complete reversal of the cognitive changes that were occurring. Another thing that anybody can do, including everyone on this call, is download an app on your phone called SnoreLab app, and it will record and measure and track your snoring and sleep quality, and will even give some guidance on how you can improve that. So it's a great screening tool, something that we should all evaluate for ourselves as well as for our family members and patients, and recommend throughout our community as something that can be utilized. So that's a good way to kind of get started on evaluating this. In the checklist within my book, The Shift, we talk about airway and breathing disorders and how to evaluate those. And then through that vertical column you see, we go into how to manage it. So basically the book is about every item that's on the checklist, what it means, why it's there, what's the research behind that, and in the case of treatment, what do we do? What's the guidance on what we do? So Tom, I hope that'll give everybody just some stimulation and understanding how airway and breathing and sleep disorders can be a big part of our dental practices, not only helping our patients to be more healthy, but there's a huge business model to this as well I didn't get into that can make our practices more healthy as well. But, you know, I just don't want there to be more patients out there like Mark Cannon's brother Jim. It's just a tragic story that should never happen in a culture and society as well developed as ours. So I'm challenging us as dentists to be on the front lines fighting the healthcare crisis that includes airway, breathing, and sleep disorders.
Amazing information. What really strikes me about what you've just presented is when we treat symptoms. For example, somebody says, I'm having headaches when I wake up, and you can see that their teeth are they've been grinding, and you're going to put in a splint, and the splint itself could cause further obstruction of the airway, and if the airway was the cause, then you're doing harm. And also you mentioned the physician at the emergency room who said you had an anxiety attack. Well, that may be true, but it was because they couldn't breathe. And of course, if you give them anti-anxiety medication, you could kill them. So just groundbreaking information, and we so appreciate your sharing. Thank you so much.
Oh, thank you, Tom. I sure appreciate it.
And I'm looking forward to speaking with you again.
Good. Looking forward to it too. Thanks, Tom.
If you found this video helpful, subscribe to the channel and hit the bell notification so you won't miss a thing. If you're not yet a GEMS family member, Elizabeth and I would be delighted to help you build your practice. We'd love to have you here with us on Planet GEMS. For a time-limited offer, a free test drive of GEMS membership, go to dentalgoldmine.com. You'll find a link in the description below. If this was helpful, please click like, and I'd really appreciate if you could share this with other dentists. Thanks so much for joining Dr. Wilkerson and me here in the Dental Goldmine, and remember, you're only one gem away.